All right, thank you everyone for coming. Happy Valentine's. So first of all, if I offended your Valentine, I'm sorry, but tell them that you always have a choice, and I thank you for choosing me over them. All right, so without further ado, um, let's talk about glaucoma. I mean, obviously this is my subspecialty. I'm an oculoplastic surgeon as well. So I'm truly a plumber, plumbing the eye inside and plumbing the eye outside. So what I want to talk about is trying to explore more about normal tension glaucoma as we realize it's becoming more and more common in our population, whether because there is a shift in the demographics or just because we are more capable of picking them up in the early stage. So the first question is whether normal tension glaucoma, is it a class of its own or is it part of the spectrum? Any takers? Who think it's a class of its own? A few hands? Part of the spectrum? Yeah. It's hard to tell, to be honest. Even if you ask me, I wouldn't have an answer, to be honest. But hopefully towards the end of this talk, we have a better idea and you can choose sides. So how common is normal tension glaucoma? So if you go into the East Asia countries like Singapore, Japan, or some parts of China, you will see a huge proportion of them are actually normal tension glaucoma. 80% of them. So the other 20% are those with what we call the common high pressure glaucoma patients. But as we move towards the western side, we see a shift. And perhaps if we go all the way towards Italy, it's pretty much similar to our patient demographics. We're seeing majority of them with high pressure, about 70% I would say as well. But like I say, because our demographics is changing, our machines are better, we are seeing more and more normal tension glaucoma coming through. So this is our discussion agenda for today. First of all, we go through the diagnosis dilemma when it comes to glaucoma, normal tension glaucoma, recognizing the risk factors, and also exploring some of the treatment options. And then you can conclude whether there is a difference between normal tension glaucoma and primary open-angle glaucoma. So, the definition is quite straightforward, it's quite simple. It's a chronic progressive optic neuropathy. You do your gonioscopy and they're open angles. There's no secondary causes such as pseudo-exfoliative material or pigment dispersion. The key over here that differentiates it from primary open-angle glaucoma is the intraocular pressure is consistently below 21. And it's usually a diagnosis of exclusion. I mean, with primary open-angle glaucoma, obviously you have to exclude other causes as well. But if you have a very high intraocular pressure, that actually helps you, give you more of a positive predictive value that this is a glaucoma as compared to a normal tension. How do we get around these two things? So first of all, how do we actually measure intraocular pressure and say that this patient does not have persistently elevated intraocular pressure? Because we know that the intraocular pressure has a circadian rhythm. During the daytime, office hours, the IOP is usually lower. And towards nighttime, it actually increases. But all the time, when we're doing our IOP measurements in clinic, is during the daytime. So that means significant amount of patients are missed because we are not picking up the spike in intraocular pressure. Right, the second part, diagnosis of exclusion. So we have to exclude all other possible causes. And it's a huge range: vascular, hereditary, compressive, infective, traumatic, nutritional, and inflammatory. So I think history is one of the very important things. So from history itself, you can pick up a lot. If it's a sudden acute onset, if there is a family history of some sort of optic neuropathy, you basically get your answer straight away. What do? So if you see someone with normal tension glaucoma, or you suspect they have normal tension glaucoma, but you're not sure, whether their intraocular pressure is truly 21 or, well, less than 21, and you can't tell or you can't rule out other diagnosis that's possibly causing it. Any idea what you do? That's why we're here. You can refer to an ophthalmologist, particularly this person. Sorry, no advertisement. You can refer to anyone in Southern Eye. So that's where I'm coming. So when this patient comes to me, how do I truly ascertain the true intraocular pressure of this patient? And what do I do in order to exclude other possible causes? So let's talk about measuring the true intraocular pressure. Anyone have any idea how we can do that? Yep, IOP facing is a great idea. Water drinking test, that's good. I was going to touch on some of these things as well. Okay, so usually in our very busy clinic, a lot of us use air puff tonometers or non-contact style tonometers because they give us a reading quite rapidly. And the other thing is that because there is no contact, it's sort of more hygienic, especially in times of COVID. We definitely want to minimize contact. However, a lot of studies are based on Goldman tonometry. So if we say that someone has a pressure that's lower than 21, we're looking at Goldman tonometry rather than eye care, tonopan, or NIDAC. Now, in saying so, I'm not saying that these other measurements are inaccurate. It's just that when you base your treatment plans, you have to be careful what you're basing on. So other tools that you can help to measure your intraocular pressure and supposedly to be more accurate in terms of the estimated pressure, it's ORA, or Ocular Response Analyzer, or something called dynamic contour tonometers. Anyone have these devices in your clinics at all? No? So the ocular, well, I'll touch on it basically briefly. So we can do IOP phasing, like you guys have mentioned before, a water drinking test. But how often, or does anyone do any of this too? That's good. Which one do you do, Rebecca? But it's quite intense, isn't it? They have to come in from the morning to the afternoon. Yeah. And the other thing, obviously, is central cornea thickness. One of the easiest things that we can do to try to identify whether we're truly overestimating or underestimating their pressure. So why use Goldman? So I briefly mentioned about because this is what the studies are based on, and if there is less intervariability if you are the person who's measuring it. Measurements between different tools are not always consistent, and in my experience, if you are using an air puff tonometer like NIDAC, they tend to underestimate the eye pressure significantly. But if you can correlate between the two readings for a particular patient, you can actually use that as a guide to monitor your patient as well. So I'm not saying or discouraging the use of other tonometers, but I'm just saying that you need to know if there is a correlation between the two for that particular patient. Goldman has its own issues, obviously. It has, so if someone comes in with very dry eyes or watery eyes, epiphora, irregular corneas, or they're just eye squeezes, it will just make your life miserable trying to get the pressure out of them. And trust me, I've done that a lot of times. So these are the two other machines that provide a more accurate measurement of your intraocular pressure. The first one is Ocular Response Analyzer. It's actually an air puff tonometer, but what it does, it takes into account the corneal rigidity. So when it puff up the air and try to flatten the cornea, it takes one measurement, and as the cornea flattens further and kind of rebounds back, it takes another measurement. So what it's trying to do is to remove the rigidity part of the cornea to give you a better estimation of your intraocular pressure. And dynamic contour tonometer, what it does is, with the Goldman tonometer, when we measure the pressure, we always assume your cornea is uniform, it's elastic, and it's like a sphere. But this is far from the truth. So with this machine, it actually takes into the surface contour into account when it calculates the intraocular pressure, therefore giving a better reading. All right, and DCT from a lot of literature always tend to give a higher reading compared to Goldman. So maybe perhaps with Goldman, we are actually even underestimating the true pressure anyway. So let's talk about IOP phasing. It's actually very intensive. So if I have a patient who comes in with very low pressure, but I'm very suspicious that it might have intermittent spike, I perhaps might do intraocular pressure IOP phasing. So this is a 2-hourly IOP measurements between 8 o'clock to 1600 during office hours. So they just come in every time for every 2 hours just to get their pressure reading. And the aim is to try to identify the highest intraocular pressure that's recorded during office time. But the take is that as we see the circadian rhythm that I show you guys, a lot of times you're getting the spikes at night, especially in the early hours of morning. And that is the time that we're missing. And we can't really possibly ask the patient to come in 5 or 4 a.m. in the morning to take a measurement, even if you are very dedicated. The second thing is that we try to identify whether there is a huge fluctuation for the patient. So if they have a fluctuation of more than 5 millimeters per mercury, it is quite suggestive that their true intraocular pressure might be even higher, especially at night. But is it enough to capture the peak? And unfortunately, if you do capture the peak, that's great news. But if you don't, it still doesn't rule it out. So what about water drinking test? I think it's pretty cruel. I've done it once. The patient still come back to see me, I don't know why. Maybe I give him juice instead of water. So you fast them for about 2 hours. So they run dry. You measure their intraocular pressure. Then you give them 1 liter of water and expect them to drink within 15 minutes, which is quite tough. I tried it myself. And you measure their intraocular pressure every 15 minutes for the next hour. And what you're trying to see is whether there is a spike of the intraocular pressure. However, this gives you more information about the impairment of your aqueous outflow. So if you have a spike, it means that your trabecular meshwork is actually not handling the increase in the fluid intake. But it actually doesn't really tell you what's the true intraocular pressure either. So if your intraocular pressure is elevated by more than 5 or an increase of 30%, it's quite significant. So I like to use water drinking test when a patient comes into me with a normal tension glaucoma and they don't want to have any eye drops. So the question is, can I offer them something else? Basically SLT. So in order to find out whether SLT works, sometimes I give them water drinking test. So if the pressure truly goes up after 1 liter of water, it means that the trabecular meshwork, the disease is around the area. And so if I target my treatment to that area, I will expect it to dampen down that fluctuation because I sort of open up the aqueous channels between the trabecular meshwork. And so next is the central cornea thickness. I don't think this needs further introduction or explanation. Everyone knows thick corneas overestimate, thin corneas underestimate. But when you look at someone, does anyone try to recalculate your intraocular pressure based on central cornea thickness? I see shakings, noddings. Yes and no. So let me introduce you this wonderful table. All right. It's not from me, obviously. It's called correction factor. I think a lot of people would just Google it and then just plug in the numbers and say, oh, let's say if I have a very thick cornea, I have underestimated by 5 millimeters of mercury, so I just add it to it. And so if you want to be even more sophisticated, there are tons of formulas that you can use. Why not try the Ehlers, Scher, Resden, colors, you know, or are they just unnecessarily complicated? So a wise man once said, when there are too many options, there's probably no best solution. And in this case, I think that we can actually just forget all about all these fancy formulas and just think very simply. If it's a thick cornea, whatever pressure you're getting, it's probably better than what you expect. I think that's the takeaway message. Don't think too hard about it. Let me do the thinking. So I just want to give you an example. Think about it, and we might come back and talk about it. So a 67-year-old gentleman with an intraocular pressure of 20 and 21, but the central cornea thickness, it's very thin because of LASIK. The gonioscopy is open, and OCT scan shows some thinning in the nerve fiber layers and the ganglion cell layer. So you make a diagnosis of pre-perimetric glaucoma. So the question is, who's going to treat? Who's not going to treat? Anyone's treating? Anyone's not treating? So after all these things about intraocular pressure, how we can more accurately determine the true intraocular pressure, and let's say we nail it, we identify that this patient has normal intraocular pressure, then what's next? We have to consider other diagnoses as well. Is it nutritional? Is it a compressive lesion, inflammatory, infective, demyelination, trauma, vascular, the list goes on and so forth. So really, if you want to truly investigate and rule out all these things, it's a huge list. And I don't think any glaucoma specialist or optometry specialist or anyone would go through all this list. And that's why history is very important. It gives you a good idea. So is your clinical examination. For most of my patients, if they come through the doors, I probably would just look at their nutritional status and maybe consider getting a scan to rule out compressive lesions, because these two are life-threatening as well as sight-threatening, and they can be easily reversible, right? The rest, some of them, it's difficult. For example, if you have hereditary component, well, you can't do very much unless you have access to gene therapy. And the rest, you can base it on your clinical examination, and they will give you enough clues to reach the conclusion. So, if that is the case, do we start MRI everyone? That sounds like a very good idea, doesn't it? MRI? No MRI? I think we are very good because we're always thinking of for the government's pocket money, trying to save them a lot more. But it's true, we shouldn't be, because there's a study that shows that if out of this 126 patients with optic neuropathy, and they were diagnosed with normal tension glaucoma, but very atypical features, only 50, so all of these patients underwent MRI scan, but only 15% of them actually have something within the visual pathway that cause optic neuropathy. And the most common causes are pituitary tumor, meningioma, and stroke. So that means that the U for an atypical normal tension glaucoma is already very low. Your classical normal tension glaucoma, you should have the confidence to make the diagnosis and move forward with your treatment plan. So when do I consider MRI scans for my patients? It's actually quite a huge list for atypical features as well, but you'll be surprised there's actually quite a small numbers that actually fit into this. So if they have very highly asymmetrical disease, so both eyes pressure 12, but one side have very advanced visual loss, or if they have a RAPD, dysphalia, decrease in color visual acuity, decrease in visual acuity that's not accounted for any mediums like no cataracts, no refractive error, the cornea is clear, retina is fine. If they have a typical neurological visual field defect, like if they have a homonymous visual field defect or if a bitemporal one, then those are the patients that I would just get an MRI. There's some patients I will also do an MRI, especially if I'm going to plan for surgery, which is a big undertaking. So if they're progressing despite having very low pressure, I think I would just do one MRI for peace of mind that we're not missing anything before we embark on this journey. Bearing in mind that any surgeries for glaucoma, especially the big one like trabeculectomy and tube implant, it's very risky. We're moving. Number 2, so let's talk about recognizing the risk factors. Oh, before I move on, any questions at all? Yeah, I think the circadian rhythm is more inbuilt and got to do with more of the sunlight, but obviously your biological clock at some stage will take over and mess it up as well. So to answer your question, I don't know whether it's switch over, whether your intraocular pressure is higher during the daytime if you do night shifts. Is that what you're asking? That's right, make things even harder. That's right. So I mean, there's 2 ways of making a diagnosis, isn't it? So first of all, if you have a matching field defect and you have OCT nerve findings, which is very consistent, then there you go. It's quite simple. You can also base it on your OCT findings, but what you're trying to establish is a trend. So you need to have series of OCTs that shows a decline over time. So even if they don't have any visual field defect, you're picking up very early disease because you have confirmed that there is a true decline. And so these are the patients what I call pre-parametric glaucoma. So whether you want to treat them, it depends on the rate of deterioration and depends on their age. So if they are, say, 85, it took 2 years for us to see some decline, I probably just leave it. But if they are 60 and it took 2 years, I think that's quite something that we have look into to try to treat them because they have another 20 or 30 years ahead of them. Glaucoma, yep. So the thing is that we know that it would take about 3 to 4 months to see a structural change. So your closest interval is 3 monthly. The reason why we want to do tests more frequently is that if you do more tests, you're more likely to identify a progression within a shorter period of time. So if someone is progressing, but very slow, not say slowly, like moderately, and you do 6 months, it might take you 4 or 5 scans to identify the change. And that means you're going to spend up to 2 to 3 years if you're doing every 6 monthly. But if you do it every 3 to 4 monthly, your confidence from the machine and the accuracy becomes better, and you may pick up a change within a year. And so that's why I would say to most patients, if you really want to keep a very close eye to make sure that you're not deteriorating faster, then we see you every 3 to 4 months. But 6 months is quite acceptable. But it would take a longer time to identify the change. That's right. So I'm definitely talking about those people at the initial phase when they first come through your door, 3 monthly to 4 monthly. And then after that, you have a good set of data and you can decide whether you want to extend to 6 months, 9 months, or even some individuals on a yearly basis. All right, and I think we're going to talk about a little bit about the risk progression because it does actually identify who you're going to treat. Compared to primary open-angle glaucoma, I guess this is the thing we are trying to think about when we have this disease, trying to see if it's a separate entity or part of the spectrum. Do they have a difference in terms of their risk factors? Are they different in terms of their rate of progression? And if we're offering treatment, do we have to make a choice, or are they similar? So in terms of history, you can take a family history, and certainly there are genes identified that can cause normal tension glaucoma, such as optic neurine, myosin, TKB1. But realistically speaking, it really doesn't matter. It's only 5% of those patients that are seeing. And in the absence of any gene therapy, and certainly not in this country, I don't think that it's worth thinking about it or spending your time to talk about it. Some people would say, oh, what if I go through those tests? You can buy it online and run the test. I always tell them, if you want something wrong with your insurance policy, go ahead and do it. It will affect your premium for sure. What about systemic vascular disease? And we know that people who have diabetes, hypertension, systemic nocturnal hypotension, and obstructive sleep apneas, they are more prone to getting normal tension glaucoma and more at risk of progression as well. Similarly, if you're female, I'm sorry, or vasospasm, such as migraines and Raynaud's, that would put you on an increased risk as well. So I think majority of you guys, as far as I can tell from the referral that I'm receiving, you guys did a very good history, always ask about migraines and Raynaud's, which is good. So what about in terms of the examination? So these are the things that will increase the risk of progression, such as the Drans hemorrhage, basically the disc hemorrhage, a very thin central cornea thickness, high corneal hysteresis. I guess if you don't have the machine that measure hysteresis, then you wouldn't be actually looking at this. And the other thing is low mean ocular perfusion pressure. Anyone has any idea what this is? The last one. I think in Christchurch Eye Department, we do a lot of low mean ocular perfusion pressure. But can I ask, somehow we stopped doing that? Or are we still doing that? We still do it. That very good, very good. It does give us a lot of information, and I think that we'll talk about this. I'm not expecting everyone to start doing, and I got a reason for it. All right, so let's go back to our very basic. So this is a schematic diagram of the eye. You have very high intraocular pressure. The pressure is transmitted through from the aqueous chamber through the vitreous, hitting your optic nerve, causing optic nerve damage. But at the same time, your blood pressure helps to maintain the perfusion of the optic nerve. So if you have very low blood pressure, then there isn't enough blood supply to the optic nerve head. And so you got what we call optic nerve hypoperfusion. But glaucoma is not as simple as that. We have to take into account of another thing, which is your your scleral rigidity. So your sclera, the way your nerve goes into your eye, they actually pass through a sieve-like material, which is part of your sclera. Lots of perforations, and therefore in glaucoma, when you see the patients, when they have glaucoma, you start to see those laminar dots and laminar holes, and that's because the laminar cribosol is actually kind of expanding. It's not expanding, but your nerves are losing its volume, and so you can see the dot within it. And so if you have a very rigid cornea or rigid sclera, that will increase your risk of getting glaucoma as well. But that's not all, because we have to look at the intracranial pressure as well. Now remember, your optic nerve is wrapped around with the optic nerve sheath, which is bathed in CSF. So if you have high intracranial pressure, it's also going to cause some damage. And last but not least, we have autonomic dysregulation of your perfusion system around the optic nerve head. So glaucoma is not a very simple thing, just intraocular pressure. There are a lot of things that influence it as well. So that comes to my next point, why we do the mean ocular perfusion pressure. So basically, we are looking at the blood pressure that helps to perfuse the optic disc. So as you can see from this formula itself, if you have very low mean ocular perfusion pressure, you're more likely to get glaucoma. And based on the formula, it is highly influenced by your blood pressure, especially your diastolic pressure, more so than your intraocular pressure. So if you have low diastolic pressure and high intraocular pressure, that is truly dangerous. The question is, how are we going to use this formula to help us to decide what sort of treatment to give to our patients, or should we even try to? There's definitely a lot of studies that establish the relationship between your diastolic pressure, blood pressure, and glaucoma risk. And these are big, robust studies like the Baltimore studies and the Barbados. So I think maybe I should take another 5 to 10 years to become a cardiologist as well. And then maybe I can treat their blood pressure at the same time. But do I really have to do that? So let's look at the validity of mean ocular perfusion pressure. So like I say, a lot of studies has already proven that, but there are also studies that shows that if you have hypertension or hypotension, both of them are associated with risk of glaucoma. So what do? If someone has hypertension, you try to give them hypertension? Oh, I don't think you can do that by making them mad. So if they are hypertensive and you try to drop them, they become hypotensive, that doesn't work either. So you're stuck in a truly hard place. You got a formula that helps you, that gives you some information, but how are you going to use that information? That's the key. So no studies to date have established the cutoff. I think most of us will say, well, 40 is kind of the ballpark figure. So if you have 40 millimeter per mercury, if it's below that, your risk is higher. But all those studies that I've shown you, where they have 6 folds or 4 folds, it's just because where they place the cutoff point. And the next thing to ask, what do we do with the cutoff? How are we going to change the blood pressure, and what's our target? Because in our IOP measurements as a glaucoma specialist, we always talk about a target pressure. So we have something to work towards too. But for this one, it's a little bit difficult. And the other thing is that there is no evidence of how influencing your blood pressure at this stage will alter the outcome of glaucoma. So I would say that this is truly a fantastic idea, but it's difficult to do in practice. Because the other thing we have to take into consideration is your blood pressure is pretty much like your intraocular pressure. It has a circadian rhythm. So how do we know that we are truly taking the trough of your blood pressure? So all in all, I would say that at this stage, the intraocular pressure controls takes priority. However, for some of our patients where your intraocular pressure is already very low, I think blood pressure is something that you can look at to try to influence their outcome. However, you can't tell your patients with great confidence that it's truly going to alter or change everything. So the risk of progression is actually very well highlighted by collaborative normal tension glaucoma study. Now this study shows that a staggering, throughout first of all, the cause of progression is highly variable for each and every individual. So it's hard to say if they have normal tension glaucoma, are they going to progress or not? Pretty much like primary open-angle glaucoma, and therefore we still have to look at them on a regular basis to see the trend. But the most important thing from this study is 65% of the untreated patients did not progress at all over the last 5 years. Only 12% actually progressed. 12% progress even if they are treated, even if their pressure is down 30%. And these are the risk factors it identifies, being female, migraine, Raynaud's hemorrhage, and genetics. So, in this situation, when you look at a normal tension glaucoma, does this actually kind of change what you're going to do? Are you going to treat the patient, or are you not going to treat the patient? And I think we have to think even further sometimes. So certainly for some patients, even if you have normal tension glaucoma, if they have central involvement or very severe glaucoma, only eye, significant family history, a lot of other risk factors, I would definitely talk about treatment with them. And ultimately, it's a patient's choice. So I would tell the patients, I usually use the number 50%. That's 50% of the times you might progress, 50% of the times you might not progress, right? But we still have to monitor you for a good few years, or actually for the rest of your life, just to make sure. All right, so now we're on the last part, exploring treatment. So for normal tension glaucoma, what sort of treatment do we have out there? Any suggestions? SLT is a good one. Drops. Surgery. So those are the top 3. Anything else you can think of? I call it the non-conventional way. And we talk about it briefly. And I think it's something that's worth discussing because nowadays everyone starts Googling and they'll be an expert in no time. And with AI, who knows, they come in and they'll tell you more than what you know. So be prepared. So first of all, let's talk about drops. We have a lot of drops options such as prostaglandin, beta blockers, alpha agonists, carbonic anhydrase inhibitors, ROCK inhibitors, and nitric oxide donors, unfortunately, are not available in New Zealand. But I think on the whole, we got enough drops to play with. We're not going to put patients on 6 drops. So sometimes it's not really worthwhile going through all those drops. If it doesn't work, it doesn't work. So this is a study, low tension glaucoma treatment study, or LOTS for short, and this explores the efficacy of timolol eye drops versus brimonidine. And this is quite a big study and important study because of this finding. So both brimonidine and timolol, they will reduce the intraocular pressure quite effectively, down by about 30 to 40%. However, brimonidine is associated with higher ocular surface disease, about 3 times. Now this is the striking finding. Progression on visual fields. If you're on timolol, you're 39%, 39% of them actually progress, whereas only 9% in the brimonidine group progress. So what's the reason? Because both of them reduce the intraocular pressure to the same level, but the outcome is quite drastic. So the biggest question over here is brimonidine, does it actually have a neuroprotective effect? Or is timolol, causing optic nerve hypoperfusion, and therefore you get further progression of glaucoma. So my key question over here, and to a lot of you guys, if you've got a normal tension glaucoma and you have these studies at hand, what's your first option to treat your patient? Yeah, based on that study, I think a lot of people will say brimonidine, isn't it? But in real life, who gives brimonidine as the first line? I don't think anyone would. That's because it's really bad for your ocular surface. I have lots of patients coming through, and before I do the surgeries for them, I actually have to stop some of the drops, and brimonidine being one of the most common one. So there's a big kind of a survey for ophthalmologists, and it turns out most people just use prostaglandin anyway. So whether these studies change your first line treatment, well, the answer is no, but it does guide you what you offer as a second line or third line treatment. What about SLT? I think it's definitely worthwhile considering SLT for all normal tension glaucoma, especially if they come in with, say, about 16 to 18 type of pressure. You know, some patients, you'll be surprised you can actually drop it down to 12. And that's a good 20 to 30% reduction. And patients who have very thin corneas will benefit as well because their true underlying pressure is probably higher. The next group is those with high IOP fluctuation. Because the reason why you do SLT is that it actually maintains the outflow in a continuous way. Because when you have medications, you get pauses of it. So there are times that your IOP actually goes quite high. Whereas for the SLT, when it dampens it down, it's a continuous effect. So for patients who are progressing, even in normal tension glaucoma, even if their pressure is about 12 to 14, I will still have a discussion with them and offer them SLT. Because if we don't, what's next? Surgeries. So nowadays, especially in glaucoma, there's lots and lots of devices coming, which is very exciting. But it also means that it's also becoming quite challenging to decide what sort of surgeries to offer to your patients. So basically, I put it under 3 categories: your trabeculectomies, your glaucoma drainage tube device, and your mix, which is like PRESERFLO, mini-jet, GET. Are you guys familiar with any of those things? No? Well, we can talk about it another day anyway. So which one do you think is the go-to option for someone with normal tension glaucoma? That is quite true. With PRESERFLO, the only thing is that we don't have the long-term data. So we don't know how long it's going to last, how often we're going to do needling. But I do agree with you, PRESERFLO is a lot easier. But as I was saying, when I consider a mix, it is something that's straightforward, something that is very safe, something that is easy to monitor. PRESERFLO is nothing like that. Right? PRESERFLO intensive post-operative management. You have to see them, quite frequently and give them lots of steroids to make sure it doesn't scar. It can go into hypotony very, very often with choroidal as well. So I'm not quite sure whether putting that it's quite right, but PRESERFLO is recognized as a mix, and same as mini-jet, which is a suprachoroidal implant as well. So all the mix that actually truly drop down your pressure significantly are actually quite high risk, not very safe. So, Anthony, you're quite right. So trabeculectomy is still the go-to, at least for me, when I'm treating for normal tension glaucoma, and also because in public there's no PRESERFLO. The thing I like about trabeculectomy for this patient is very controlled. So if I see them on day 1, if their eye pressure is very high, I can actually try to bring it down just by gently massaging the wound that I've created for them. So it's a very controlled manner. And so achieving a pressure less than 10, it's very possible. It also helps to dampen down your IOP fluctuation and maintain it at a steady state. So these are definitely recommended for those patients who are progressing, even if their eye pressure is in low teens. But the risk is high, like I mentioned before. So the last part of my talk, we're coming to an end, bear with me, is a non-conventional approach. Any ideas what these are? Yep, ginkgo. Yeah, that's right, meditation. Some sort of supplements, specifically B3. All right. So ginkgo, I think quite a number of us, including ophthalmologists, will recommend ginkgo for our patients if they have normal tension glaucoma. But let's have a look at the evidence for it. So it's an antioxidant. There's a very small RCT back in 2003 that shows that if you take ginkgo, you get an improvement of your visual fields in patients with glaucoma. And therefore, it's suggested that it has this neuro protective mechanism, or actually recovery mechanism, so that you actually get an improvement. However, subsequent studies are very small and they show a lot of inconsistency. And there is no large clinical trials up to date. So with this information, would you still offer ginkgo? That's right. So that's the other thing. It's like taking garlic. What else? Those herbal medications can put an increased risk of bleeding. Anyone? Well, actually, sometimes I do. Why? Because I have nothing to offer, and I feel I have to offer something. And I think for some patients, if you say ginkgo, that's easy to get, but obviously you have to tell them about the bleeding risk. So, as far as we consider weak evidence, what about nicotinamide? This is actually B3. So this is based on a nutritional examination survey looking at dietary niacin intake and glaucoma, and they found that 1 milligram increase in niacin intake is associated with a 6% decreased odds of glaucoma. However, all the studies follows are all associations. There is no randomized control trial once again. And perhaps this one is not even weak, it's actually even weaker. But, it's still some value. What about mindfulness and meditation and exercises? Well, it will increase your mitochondrial biogenesis and reduce your oxidative stress. So that's supposed to be good for your optic nerve and the perfusion. There's a lot of studies, sometimes outside medicine, that shows that meditation and exercise is a good adjunct treatment, not as a primary treatment, of course, but potentially very biased, and it's very difficult to ascertain, its effectiveness. But I mean, with meditation and exercise, nothing could actually go wrong. So if my patients say, does mindfulness work? I just nod my head, absolutely. That makes them happy and makes me happy. So my key message to you guys today is that normal tension glaucoma, it's very common. However, sometimes the diagnosis can be challenging. You only need to miss 1 or 2 normal tension glaucoma, well, miss 1 or 2 pituitary tumor or some sort of tumor, and that will scar you for life. Treatment options are very similar to primary open-angle glaucoma, and remember, observation is definitely an option. Intraocular pressure may be very difficult to achieve. I'm talking about a target, but so that means sometimes we can actually think outside the box and think about blood pressure or some non-conventional stuff. So these are my references, and thank you very much for spending your Valentine with me. I think you are doing very well for time. Okay, if there's any questions, feel free to ask. Yes. Yes, well, so basically how it actually depends what sort of medications as well. So a lot of times beta blockers takes about 6 to 12 hours to work in the system anyway if you're taking it orally. So if you take it at night, the effect is going to come in, say, it depends on what time you go to bed really, maybe 4 or 5 a.m. in the morning. And that is when your intraocular pressure is also the highest. So remember what I say, if you have the high intraocular pressure and very low diastolic blood pressure, you get a your nerve is most at risk. So for patients who are taking hypertensive medications at night, just because out of convenience, then I'll say, why don't you take it during the day? So for those types of advice, I will actually, dish out quite easily, because it actually doesn't mess around with their blood pressure. It's just trying to avoid that trout in the middle of night. Nocturnal blood pressure test. So if he does the blood, so my key question is, I mean, as I said, all these are very informative, but the key thing is that when the patient comes back to you and tell you that there's a problem, what are you going to do with it? You need to be certain that you are able to do something about it, rather than go back to your GP or go back to see someone. That's kind of like, I identify an issue, but I can't solve it. I don't know how to solve it and expect someone to solve it. But that's where I'm coming from. So I say it's a very good idea. You can talk to patient and do that, but then you need to know what to do after. And one last thing I want to do is to save your sight as an organ and sacrifice your heart and brain. You know, have a massive heart attack or a stroke. And say, oh yeah, I saved your sight. You're all good now. I'm sorry, you can't see anyway because you got a stroke. So that's not a good exchange. No, there's actually no limits as well. So I would say, so for all the patients nowadays, I offer SLT. I would try at least twice. So if I do the first time, if it doesn't work, I might discuss it with them again. We can try a second go. If the second go doesn't work, just forget about it. It's not going to work. In terms of repeatability, I'll repeat as many times as required if it buys me 1 year to 2 years time. So if I have to repeat every 3 months, no go. But if I repeat every, say, 18 months to 2 years, I think it's very worth it. And I still have, I think I kind of did a study as well, and it was published. It shows that patients who have up to 3 SLT is still working. And I was working on the 4th SLT, and it still works in some individuals. So yes, you can keep repeating until it stops working. Yeah, so I always tell my patients, I mean, it's a ballpark figure, but I would say 80% of the time it works. The next time you have it, it's another 80%, which means it's 64%. So each repeated treatment, your rate of success goes down. So whether they want to do it is really up to them. But I think in my opinion, I've seen enough ocular surface disease, and I'm sure you guys have seen a lot. People coming in with red eyes, irritable eyes, crying for help. You know, if they have SLT right at the get-go, they wouldn't have these problems at all. And the other thing with all these eye drops that we're giving to our patients, especially in New Zealand because we have preservatives inside, it actually causes chronic inflammation of your ocular surface, and this can lead to your trabecular meshwork failure. So we are actually giving them drops to help them now, but we're setting them up for failure in the next 10 years' time. So that's why my practice nowadays, if we can get SLT on board, we just do it. And I try to sell it as simple as possible. I say it's an effective treatment, it's a go-to treatment. Just think about it. You don't need to have eye drops. And drops are toxic, in a way. And that will sell them, you know, quite well to get an SLT, even in public patients. In New Zealand itself, actually, I actually don't know what's the study. I've been trying to find out, but I don't think we do have a paper on glaucoma, but it's definitely not 80–90%. It's less than 50%, that's for sure. For no, only for primary open-angle glaucoma. Yep. Of in general. Yeah, yeah, that's right. But I actually don't know. I'm sorry. Yeah, I didn't look at the literature enough. My bad. Only when they're progressing. So I wouldn't say it straight away. If they're yes, that's right. So don't take away I mean, the little old lady, maybe she's 89 years old, right? She shouldn't be bending over for a lot of reasons, like falling over. But if you take that away from her, are we going to change the outcome at all? She's 89. Her field looks not too bad. How long more has she got to go? 10 more years? And you're going to take away her hobby for the next 10 years? I'd probably just let her do her own stuff. So you're quite right. Age plays a very big factor in deciding whether to treat them or not. It's actually quite different. They're quite variable, but on the whole, most of them actually don't progress. Not as fast. Yeah, not as fast as primary open-angle glaucoma. And that's because the eye pressure is lower. And that's perhaps one of the key reasons why they're not progressing faster as well. Right? Thank you very much. I think we still have some food left over. Yep. Help yourself, have some drinks. Salad Valentine's.